Buenos dias. Good morning. My name is Jose Szapocznik. I'm a professor of public health sciences at the University of Miami. I'm your moderator for this panel. Today, we will be talking about opiate use disorder and COVID in the United States and in the Americas. We are very fortunate to have three very distinguished speakers. I will introduce one speaker all three speakers initially, and then they will go ahead and give their presentations. The first speaker is Dr. David Fiellin. Dr. Fiellin is a professor of medicine and public health at Yale University and inaugural director of the Yale University program in addiction medicine. He has focused his scholarly work on the interface between primary care, general health care settings, and addiction. He is board certified in addiction medicine and prevention medicine in the United States of North America. He conducts research on the transfer of treatment for opioid use disorder and alcohol use disorder from specialized substance abuse settings to office-based primary care, emergency department, and HIV specialty settings. He has received many honors, including from the American Society for the Treatment of Opioid Dependence, the American Society of Addiction Medicine, and the Hazelden Betty Ford Foundation. He's on the editorial board of the Journal of Addiction Medicine, the Journal of Substance Abuse Treatment and Substance Abuse. He received his medical degree from Emory University and completed his internal medicine fellowship at Yale University. Our second presenter is Dr. Paul Joudrey. Dr. Joudrey is an assistant professor in the Yale School of Medicine and a Yale drug use addiction and HIV research scholar. Dr. Joudrey is committed to improving the health of people with substance use disorders by expanding access to high-quality, evidence-based care. His research interests include expanding access to methadone for opioid use disorder in rural communities and improving the adoption of medications for alcohol use disorder within hospital settings. He employs implementation science methods to expand the adoption of evidence-based practices. A practicing addiction physician, he's certified as a general internist and addiction medicine specialist in the United States of North America. He received his medical degree from New York University and completed his resident training at Montefiore Medical Center. And our last but definitely not least of our presenters is la doctora Coralee Pérez Pedrogo. Doctora Pérez Pedrogo is an assistant professor in this Graduate School of Public Health at la Universidad de Puerto Rico and an associate professor at la Universidad Carlos Albizu, also in Puerto Rico. Dr. Pérez Pedrogo has experience working in outpatient clinics and inpatient psychiatric units with patients with substance use disorders, anxiety disorders, and affective disorders. In addition, she has over 12 years experience in conducting clinical research that include providing manualized, culturally adapted, evidence-based interventions for alcohol prevention, conduct disorders, and affective disorders. Dr. Pedrogo is currently the principal investigator of two studies funded by the National Institutes of Health in the United States of North America. Dr. Pérez Pedrogo received her doctorate in clinical psychology from la Universidad Carlos Albizu in Puerto Rico. She has received a number of honors, including el Premio Carlos y Armida Albizu from the Asociación Psicológica de Puerto Rico, and the Most Distinguished Professional Award for Professional Excellence from la Universidad Carlos Albizu. Please welcome. Actually, I was going to say please welcome as if you could applaud, but you can't. perseverating from the past. So we will start with Dr. David Fiellin. Dr. Fiellin, please go ahead.
Thank you, Dr. Szapocznik, and thank you to everybody. Buenos días and muchas gracias for having me here. I appreciate this wonderful opportunity. I know you heard this morning a little bit from Dr. Nora Volkow about the opioid epidemic, and I'll walk you through that. We'll talk about the impact of COVID on access to treatment and on our patients with opioid use disorder. And then Dr. Joudrey will speak to you about issues of access to opioid use disorder treatment and how those have been impacted by COVID. And then finally, Dr. Pérez Pedrogo will speak to us about the current state of affairs, epidemiology, and access to treatment for opioids in Latin America. So thank you very much for this opportunity. So just one slide to demonstrate the extent of the overdose epidemic in the United States. What's important to note here is that for a period of time, essentially 2000 to 2013, the number of overdoses was gradually rising but relatively flat. And the epidemiology was changing from heroin, an illicit opioid in the US market, to one of prescription opioids. And I think that's relevant for Latin America and other parts of the world to think about as they start to increase access to prescription opioids for the treatment of palliative care and chronic non-cancer pain. Hopefully you will avoid the scenario that unfortunately we've seen in the US. What you'll notice in this graph, and is around 2014, 2015, you see a sharp rise in overdose deaths and overdose events. Much of this relates to a toxic drug supply with both licit and illicitly manufactured fentanyl and other high-potency synthetic opioids, shown here in purple. And this slide is just to remind us that, at least in North America and the US, we've had a series of opioid epidemics, quite frankly, not just one, starting way back at the 1900s at the bottom here with morphine, in the 1960s and 70s with the heroin epidemic that really fueled much of the hepatitis C and HIV transmissions in the US. And then on top of that, was added this scourge of the increasing supply of prescription opioids that took advantage of the established market. And then subsequent to that, there was an increase in heroin. And as I pointed out earlier, at this point, almost all parts of the United States are seeing primarily fentanyl analogs and high-potency fentanyl analogs in all of the heroin supply, all the fentanyl supply, and even in some of the stimulants such as cocaine and other supplies. So it's very problematic. This slide, at the bottom, you can see the standard daily doses of prescription opioids per million individuals in 25 different countries. And you can see all the way on the left, the US uses multifold many more prescription opioids than the rest of the world. And this is really sort of a cautionary tale around what can happen if you're unregulated in the release of prescription opioids, even when they're used appropriately for the treatment of palliative care, and perhaps inappropriately and beyond what the evidence supports for the treatment of chronic non-cancer pain. And this slide just reminds us that there are companies out there, the biggest one being Mundipharma, which manufactured, when they were in the United States, the medication called OxyContin that just sort of seemed to fuel much of the prescription opioid epidemic in the United States. And these companies are looking now very much at the international market, since they've had challenges growing in the United States over the last 10 years. So the scope of the problem is beyond just the level of overdose. estimated that there are 11.5 million individuals in the United States with non-medical use of opioids, probably upwards of 3 to 4 million individuals with a diagnosed opioid use disorder. This has profound impacts on their jobs, their friends, their family, their social functioning, profound financial impacts, upwards of $504 billion, as suggested by the Council of Economic Advisors, and obviously a number of infectious complications routinely in our hospitals. We're seeing increased rates of infectious endocarditis. We've had major outbreaks in both urban and rural settings of HIV and hepatitis C related to injection drug use. And then also in newborns, we see increase in the proportion of individuals and, frankly, the number of individuals who are born with neonatal abstinence syndrome. And then, as I pointed out earlier, the tip of the iceberg are the deaths that we're seeing. But I think it's important to realize that that is the tip of the iceberg. As terrible as each of those events is, there's a lot of other people who are suffering as well. So our treatment strategies, the most effective treatment strategies that we've been pursuing are the opiate agonist treatments, and that's typically methadone and buprenorphine. There are other treatment strategies that are pursued. Oftentimes the pharmacologic withdrawal or the detoxification followed by medication-free treatments unfortunately leads frequently to relapse. It's probably about 80 to 85% of individuals who go through that type of treatment strategy who will relapse within 6 months to a year. And because they're no longer physically tolerant, they're actually at very high risk for overdose mortality. There are some patients who are able to get on opiate antagonist treatment with naltrexone. There's a extended release formulation that is an injection once a month. And if patients are able to get onto that treatment, then they can do almost as well as if they were receiving methadone or buprenorphine. But at this point, methadone and buprenorphine seem to be the gold standard for treatment, along with psychosocial counseling. In fact, Dr. Volkow, who's the director of the National Institute on Drug Abuse, and Francis Collins, who's the director of the National Institute of Health here in the US, spoke very eloquently about the role of science and the role of these medications in addressing the opioid crisis. And the medications basically have two basic properties. They bind to the opioid receptor, and so therefore they prevent withdrawal and relieve the craving that an individual might feel. But also because they're bound to the receptor, if somebody were to use an opioid while they had this medication in their system, their euphoria would be blocked. And these medications are really considered the gold standard of care. They've been demonstrated over time to increase retention in treatment, to decrease drug use, decrease overdose death, decrease hepatitis C and HIV transmission, and to decrease criminal behavior, and have been endorsed by any number of both federal and international agencies. Just for those who may not be familiar, buprenorphine is a partial agonist at the opioid receptor. We're used to thinking of full agonists such as methadone, morphine, and heroin. Its efficacy in the treatment of opioid use disorder is similar, although perhaps a little less than methadone. But the advantage is it can be prescribed by physicians and clinicians in their office. And I'll describe later that methadone is highly restricted to specialty treatment centers in the United States. And it's dispensed at community pharmacies and not just at special treatment programs. This slide just reminds us of the pharmacology of buprenorphine. It's the one in the middle, and it has a ceiling effect. As you increase the dose of buprenorphine, you only get so much activity at the receptor. And so because of that ceiling effect, it's a safer medication, difficult, if not impossible, to overdose on. This slide shows the proportion of individuals around the United States who are not receiving addiction treatment, who need that treatment. And you can see that the numbers on the right range from 77% to almost 100%. the darker is worse. And so there are a lot of parts of the United States where there are individuals who need treatment for addiction are not able to access that treatment. This slide shows the specialty treatment programs in gray, and those counties that have specialty treatment programs here are highlighted in gray. So all the other counties and all the other parts of the United States do not have specialty treatment programs. And so you can see a large part of the United States does not have access to specialty treatment through, for instance, an opioid treatment program or a methadone clinic. So this has led for us to start thinking about treatment of opioid use disorder in a general practice setting or a general medical setting. First of all, that's where the patients are. We have an established national healthcare infrastructure with offices all over the United States. There's less stigma associated with receiving your care in a general medical setting than a specialty setting where patients may be afraid or less likely to go. And then you're less likely to interact with people who are not in remission and those who are perhaps a bad influence if you get your treatment in a general medical setting. I'm a general internist, a primary care physician, and patients who are waiting to see me are waiting amongst all my other patients who are getting treated for their diabetes or their high blood pressure. We also, in primary care, we have longitudinal patient-provider relationships, and we're able to integrate the care of both medical issues with depression and routine health maintenance. So this slide sort of depicts where we were 20 years ago with the two treatment systems. You can see that we only had methadone available, and then in 2002, buprenorphine became available. And in the last 20 years, we basically doubled, if not tripled, the number of individuals who are receiving this gold standard treatment by adding buprenorphine to the treatment system. But again, I'm highlighting the fact that the treatment system for methadone is highly regulated and comes through these opioid treatment programs, whereas the treatment system for buprenorphine is through physicians' offices and medication dispensed at a pharmacy or a chemist. This slide shows, despite expanding access to both methadone in the dashed line and buprenorphine in the, the buprenorphine in the dashed line and methadone in the dashed and dotted line, that there's still a large gap between the proportion of individuals in the top line who need treatment and those who are actually accessing treatment. And so with this epidemic, we've failed to keep up pace in getting people access to treatment. And then all of a sudden, COVID-19 hit. And that just made all of these scenarios worse. First of all, unemployment has increased. There's also people have less time to stay busy, and so they increase their use of opioids. There's a less reliable drug supply, and so more toxic supply. Treatment centers had difficulty opening slots or having slots available. And then this is a patient population that also has a high prevalence of things that lead to poor COVID outcomes, so a high prevalence of smoking and lung disease. Many of our treatment centers tried to switch to telehealth and teleconsult visits. And our program in addiction medicine has created guidances for patients, for clinicians, for youth, and for hospital-based providers to help them address the impact of COVID-19 on the population with addictions that we serve. This slide shows the increase in the persistent increase of overdose deaths with COVID. You can see as of January 2020 and moving forward, there's sort of precipitous rise, and it's estimated, it varies from jurisdiction to jurisdiction, but at least a 10 to 15% increase in overdose mortality in the United States as a result of the COVID pandemic. Because of this, there have been discussions and actual changes in the regulatory status of and how we provide these medications. those who were receiving methadone from an opioid treatment program were allowed to go from having their medication picked where they had to pick it up every day. So now they get a take-home medications for between 14 to 28 days. The requirement that patients have an initial in-person visit was removed for individuals who wanted to start a treatment course with buprenorphine. So you could now have that entire treatment episode initiated and continued via telehealth. And then in addition, there were other telehealth requirements that were loosened by the regulatory agencies in the United States. We've had the opportunity, I've worked with Dr. Szapocznik with NIDA and the National Institutes on Drug Abuse on a clinical trials network methadone access task force. And we looked at strategies where we could potentially, through research, increase access within current regulations outside of opioid treatment programs, such as pharmacy administration of methadone, or within current regulations, such as prescribing of methadone for opioid use disorder. But it's clear that we have a lot of research that's needed on the efficacy of providing methadone in general medical settings, the use of various methadone treatment component structures in general medical settings versus opioid treatment programs, a stepped care approach where we think about transitioning patients who are not benefiting from buprenorphine to methadone in an office-based setting rather than transferring them to a specialty treatment program. And then looking at what happens when we make methadone more widely available on both fatal and non-fatal overdoses in the community. This is a healthcare workforce issue because most clinicians have not been trained on how to use methadone, and it has some issues around risk that they need to be aware of. And then we're also at the point where we're not sure exactly which patients might do best in a specialty setting versus those who might do best in a lower resourced office-based setting. So a lot of implications that this has raised for access to treatment in the United States. So in conclusion, the opioid crisis in the US has been made worse by the COVID-19 pandemic and has hastened the need for research on improving access to opioid agonist treatment, including methadone, through general medical settings.
Thank you, Dr. Fiellin. Dr. Joudrey will present next.
Thank you, everyone, for the opportunity to share my team's research today. I'm going to be picking up where Dr. Fiellin left off, and I'm going to be presenting some data from that our team collected examining the impact that COVID-19 had on the availability of medications for opioid use disorder within the United States and Canada. And specifically, I'm going to present data examining access to methadone. And so, as Dr. Fiellin was describing earlier, and I think many of us clinically who work with populations that use drugs, as COVID-19 unfolded, I think there was an immediate concern that this would worsen the drug overdose epidemic and the trends that Dr. Fiellin described. And unfortunately, what we're seeing is that the early data that's emerging out of COVID-19 that's examining overdose events is confirming this. This is just one example study that was published in JAMA showing an increase in emergency room overdose events within Virginia since the start of COVID-19. And so we know already that COVID-19 is having an adverse impact on opioid use disorder outcomes. And so, as Dr. Fiellin mentioned, one of the primary treatment options we have to reduce overdose deaths is methadone, and which is a full opioid agonist. And we know that when patients have access to this medication, we can prevent overdose events. And in fact, there's actually good research showing that when patients face delays in access to methadone for opioid use disorder, that this is associated with increased illicit opioid use, and it's also associated with increased mortality. And so we have robust data showing that if patients face delays in access for methadone, we know that that's associated with worse outcomes. And so part of the reason why we decided to focus on methadone were for some of the reasons that Dr. Fiellin alluded to. Within the United States, methadone can only be provisioned within these federally certified opioid treatment programs. And these programs have to meet a set of requirements that are actually required by law. And there's sort of a one-stop place to receive methadone for opioid use disorder. Physician evaluation occurs there, administration of the medications, dispensing of the medication occurs there. Behavioral treatment is a required component of receiving methadone at an opioid treatment program. And then even the administration requirements, how often the patient has to present to the clinic, is explicitly described within the laws and regulations governing opioid treatment programs. And we wanted, though, to contrast this regulatory structure of the opioid treatment programs in the United States with Canada, which makes methadone available for the treatment of opioid use disorder, but places less regulatory burden on its provision. And so within Canada, methadone prescribing is allowed both within addiction specialist settings, but also within office-based or primary care settings. And then methadone administration and dispensing, where patients pick up the medication, can actually occur within community pharmacies. And so both countries have taken a very clearly different approach to making methadone available. And so one question we wanted to ask was, how do these two systems respond to the disruption of COVID-19? And then the other thing that we know is that both countries took steps to adapt to the disruptions of COVID-19. Both countries relaxed requirements for how often patients have to present in person to receive methadone. And so that was similar within both nations. And both countries made steps to make telemedicine more available and increase that as an option during COVID-19. Within the United States, though, telemedicine for methadone was only allowed for established patients. It could not be used to initiate methadone. Within Canada, telemedicine for methadone was actually allowed prior to COVID-19, but professional organizations came out and recommended increased utilization of it in the setting of the pandemic. And so, given within this setting, we sought out to assess the timeliness of methadone access among methadone clinics within the United States and Canada during the COVID-19 pandemic. And we had two hypotheses for this research. The first being that more Canadian methadone clinics will be accepting new patients relative to US methadone clinics. And our second hypothesis was that Canadian methadone clinics will offer a timelier first appointment relative to US methadone clinics. And we were grounding these hypotheses in the fact that the less regulated, more flexible Canadian system may provide for this opportunity. And so to address this research question, so we identified methadone clinics within regions with the highest rates of opioid overdose deaths. And we excluded clinics that were only serving special populations, such, for example, veterans within the United States. We excluded clinics with wrong phone numbers that did not in fact offer methadone treatment, and or those requesting individual identification information at the time we contacted them. And we included all methadone clinics within 14 states and territories within the United States, and then 3 Canadian provinces within Canada. And we identified the clinics using basically government-created public treatment directories. In the case of the United States, it was the SAMHSA's Behavioral Treatment Directory, and then within Canada, it was the provincial treatment directories within each province. And so to assess access, we completed a series of standardized mock patient calls requesting the earliest methadone appointment. And the callers presented with a common presentation without evidence of other chronic medical conditions, and they requested an appointment to start methadone as soon as possible. Within the United States, we called each clinic twice, once as a patient with Medicaid, and then a second time as a patient without health insurance, what we call self-pay. The reason why we did this is that research shows that about 2/3 of patients receiving methadone in the United States pay for the services with one of these two options. And then in Canada, we called each clinic once as a patient with provincial insurance. With their single payer system, all Canadian citizens are able to pay for methadone services using provincial insurance. And we completed the calls during May 11th to June 17th. That's when data collection was completed. So our primary outcomes were whether the clinic was accepting new patients upon contact, and then how many days until the first appointment. We did have some secondary outcomes. Callers asked if among clinics that weren't accepting new patients, was this because of COVID-19? We documented if the clinic offered what's called an open access model. And that simply means that instead of scheduling an appointment for a patient, the clinic offers regular times when patients can just show up and start treatment without an appointment. And then we documented if it was possible to start methadone at the first visit. We documented the adaptations that the clinic made in response to COVID-19. And then finally, we created a composite outcome that combined the cascading events necessary for timely methadone access. And that being successfully contacting the clinic is accepting new patients, the clinic offered an appointment, offered methadone at the first visit, and then was able to schedule an appointment within 1 day of contact. So collectively, those things together represent timely methadone access. And so this is our cohort. We started with 342 clinics in the US, 323 within Canada. And what I'll just highlight here is that we successfully contacted 90% of clinics during our Medicaid calls and self-pay calls in the US. And we successfully contacted 82% of clinics in Canada. So turning to our first outcome and our first hypothesis, so we found that there was no difference across countries in terms of the number of clinics accepting new patients. It was in the high 80s during Medicaid calls, during self-pay calls, and then during calls to Canadian clinics. But we did find that around 7 to 5% of clinics providing methadone treatment were not accepting new patients due to COVID-19. So we found an evidence in the reduction in the number of clinics accepting new patients due to the pandemic. And then turning to our second outcome, focusing on the mean days to first appointment, we found that the mean days to first appointment was greater during the two types of calls, Medicaid and self-pay, to US clinics relative to Canadian clinics. So we find it was a mean of 3.5 for Medicaid, 4.1 for self-pay, and then a shorter time of 1.9 days among Canadian clinics. And one thing I want to point out here is just below that, you'll see that the percentage of clinics in the US versus Canada that operated with an open access model, again, having open slots where people can just come in to start treatment, was greater in Canada. And in secondary analyses, open access model availability was associated with shorter or timelier access in both countries. And then in terms of our composite outcome, this shows, the cascade as you move from left to right, the portion of clinics that were able to offer timely access through each of these steps needed to provide that access. And what we found is when you add all these up, around 40% of clinics in Canada were able to offer timely access to methadone, but in the United States, it was less than 25%, and this difference was statistically significant. And then some of our other secondary outcomes in terms of adaptations to COVID-19. So we did find, one thing I want to highlight here, we found that a majority of clinics within both countries reported utilizing telehealth in response to COVID-19. So this technology was being utilized. I will note in secondary analyses, we did not find telehealth adoption was associated with timelier access. However, telehealth adoption may have other benefits for patients, and certainly it may reduce the risk of transmission of COVID-19. The other thing I'll note is that what this data shows is that the opiate treatment program model required greater adaptation. There was just a higher frequency of adaptation reported within the US clinics. So main conclusion, kind of the first point here is that methadone was, during the pandemic, methadone was not available at over 1 in 10 clinics. And these were clinics that were publicly identified as offering methadone. And then we found that about 5 to 7% of those clinics were not offering methadone due to COVID-19. So we did find evidence of a reduction in treatment availability due to the pandemic. And then we also found, in the context of the differences between these two methadone delivery systems within each country, that the United States was not able to offer as timely access to methadone compared to Canadian methadone clinics. But we should also note, we identified barriers to timely access to methadone within both nations. So the implications for this, our results suggest that open access model is likely to increase timely access to methadone. In both countries, one thing that this data suggests could improve access to treatment by encouraging the adoption of that model. And unfortunately, this data shows that previous estimates of a shortage of methadone access that exists in both countries is likely worse than previously estimated. And then finally, our results to suggest that the opiate treatment program model in the US required greater adaptation. So there are some limitations. There is a possibility of response bias with this work, although we did have high response rates. This only represents results from May and June, and results may differ at different points in the pandemic, and we did not assess U.S. private insurance. And I'd like to thank the whole team that helped with collection of this data.
Thank you, Dr. Joudrey. Appreciate that excellent presentation. And next, Dr. Coralee Pérez Pedrogo.
Hi, good morning. Buenos días. I'm Coralee Pérez Pedrogo from the University of Puerto Rico Medical Sciences Campus and Alviso University. I want thanks to Dr. David Fiellin for his invitation to be part of this panel. The presentation aims are to describe the epidemiology of opioid use disorders, the provision of medications, and facilitate examples of change in opioid use disorder treatment in Latin America. Latin America has a rich history of global immigration represented in the diversity of drug use, epidemiological, and diagnostic data. Despite drug use is a growing problem in Latin America, the data available is limited, and the demand for opioids changes by region because of different countries' social and geographic characteristics. So we will present some findings identified in research projects conducted by inter-American societies as well as academics and researchers in the field. We will start presenting Puerto Rico overdose mortality trends, where, as you can see on the slide, mortality trends have been decreasing since 2000. As treatment slots increased, and that trend has continued to date. Puerto Rico has not experienced an opioid overdose epidemic when compared to the US. Nevertheless, the increased availability of fentanyl observed in the drug markets reported by staff from harm reduction and office-based buprenorphine treatment programs needs to be monitored. Its potential to exacerbate risky drug behaviors given the medication's faster elimination and shorter duration of action, just 30 to 40 minutes, that increase injection frequency. In addition, from the 2016 household survey, the most recent available, 2/3 of those endorsing past 12-month diagnostic criteria in Puerto Rico did not receive treatment in the previous year. In 2019, the Inter-American Drug Abuse Control Commission, CICAT, for its Spanish acronym, carried out a research project on opioid drugs. 5 Latin American countries participated: Argentina, Mexico, Peru, the Dominican Republic, and Uruguay. What were the main findings? Well, in terms of opioid use, the prevalence in Argentina, Peru, and Uruguay are low. It is higher in healthcare workers where they received treatment with methadone or buprenorphine. Since we have lower rates of opioids among these countries, this is not Mexico's scenario. So, were the main findings in Mexico in terms of opioid use? Well, civil society organizations reported that the increase in overdose cases is associated with fentanyl use. Mexico also has the highest incidence of use than Latin American countries because of its border with the United States. In terms of using opioids in regions other than the country of origin, the people in Argentina use opioids in Europe or USA. In the Dominican Republic, the people who use opioids have a long history of drug use, and 70% of them used heroin for the first time in the US. In summary, the onset of heroin use began in countries and regions where heroin use is more common, such as in Europe or the United States. The same study conducted by CICAT in 2019 also examined opioid treatment, and they found that in Argentina and Uruguay, for example, the demand for opioid treatment is low. Since in Peru no significant level of opioid use is perceived, health service providers do not always have adequate information about the opioid problem and how to address it. In contrast, in the Dominican Republic, 61% of people with opioid use disorder received outpatient treatment and 39% in residential settings. Buprenorphine is well appreciated among people treated and with this medication that started in a pilot program initiated in 2017. Dr. Albizu Garcia and other team members from the University of Puerto Rico conducted an evaluation of this pilot project. The results have contributed to a policy decision to expand treatment and add methadone as another treatment option. In conclusion, treatment with methadone and buprenorphine is a valued treatment among people with the condition. What do you know about harm reduction programs? Well, they have had little presence in Latin America, except in Brazil and Argentina, where, in addition to methadone programs, syringe distribution campaigns to prevent the spread of HIV have been implemented. Mexico and Puerto Rico seem to have a comprehensive program for alternative treatments and exchange of needles and syringes. Now, I will present a preliminary study's main findings entitled Overall Impact of the Pandemic in the Addiction Treatment Centers of Latin America. The study aims were to explain the overall impact of pandemic and isolation measures in treatment centers and identify changes in demand for treatment by institutions. The study consisted of a multi-center design in Argentina, Brazil, Chile, Ecuador, and Mexico. The selection of the treatment centers was carried out using the snowball technique within each chapter. One of the main findings was the advantages related to the implementation of virtual care. Some of them were greater therapeutic approaches through virtual meetings and therapeutic accessibility for users living in other cities. On the other hand, the identified disadvantages were impossibility of access to treatment among people without access to virtual media and lack of privacy at home for the development of treatments. The investigator also explored changes in demand for treatment by institutions. One of the questions they formulated was if more people with substance use disorders came to treatment for their own will. They found an increase of 50%. They also explored the demand for treatment among women, where they found an increase of 30%. The COVID-19 pandemic has presented unique difficulties and exceptional opportunities for the treatment of opioid use disorders, and Puerto Rico is not the exception. In community centers, the difficulties stem from both the threat of COVID-19 infection and the steps taken to diminish the threat, most especially governmental mandates for closing non-essential services and social isolation. For people actively using drugs, control efforts have reduced their opportunity to obtain safe harm reduction supplies, including syringes, and to engage with opioid treatment providers. On the other hand, social isolation can introduce perturbations in the drug supply that increase overdose risk. Nevertheless, as mentioned before, unique opportunities have emerged from the COVID-19 pandemic. Once SAMHSA lifted restrictions for opioid treatment programs, most community treatment programs moved to expand the number of take-home doses dispensed to their patients to decrease clinic occupancy following social distancing requirements. Initial reports reveal positive impacts, such as increases in new patient inductions. Other advantages are the relaxation of methadone dispensing regulations for opioid treatment programs, reducing incarceration, and expanding resources and staff support for harm reduction programs. This will centrally increase the ability of programs to expand services and reduce the chances of HIV outbreaks among this population. Methadone maintenance treatment programs in the Puerto Rico prison system adapted services to secure treatment continuity. While providing protection from contagion, take-home doses were dispensed upon release to avoid medication interruptions during the initial post-release days. Our conclusions are the following. In terms of the epidemiology of opioid use disorders in Latin America, although 80% of the world's population is located in developing countries, where consumption in these areas is low, Latin American countries must adopt measures to maintain or reduce their current low levels of opioid consumption while fighting pervasive use of alcohol and other drugs that impact public health. It is essential paying attention to those countries most affected by opioid drug epidemic, such as Mexico, Dominican Republic, and Puerto Rico. In terms of provision of medication, methadone and buprenorphine are valued treatment options among people with opioid use disorder. Harm reduction programs have little presence in Latin America, except in some countries. Additional efforts must be implemented to increase accessibility and reduce morbidity and mortality among people with opioid use disorders. Finally, since we have identified challenges associated with the provision of opioid drug treatment during the pandemic, it is important also to recognize that opportunities have been emerged due to COVID-19 to increase the ability of programs to expand services and avoid treatment interruptions. Once again, I want thanks to Dr. David Fiellin for his invitation to be part of this panel. This presentation was made possible by a supplement grant from the National Institute on Drug Abuse at the National Institutes of Health. Thank you to my mentors for all their support.
Thank you so much, Dr. Pérez Pedrogo. I want to ask the audience to ask any questions or any comments you may have in the chat that's available to you in the lower part of your screen. At this point, I don't see any. Oh, I see some comments that are just coming in. But I'd like to start with a question of mine for Dr. Fiellin. By the way, we only have 9 minutes left, so please keep your answers brief. I think it'd be helpful to the audience if you could talk about, talk to the primary care physicians, the HIV care physicians, and the emergency doctor physicians in this audience about bringing methadone and buprenorphine to their practice.
Thank you, Jose. I think the recognition that substance use disorders are similar to other general medical disorders that we see, and that there's both a medical aspect and a behavioral aspect. So it's not unlike the types of assessments that we do in patients who have mild to moderate depression or diabetes or high blood pressure, where we work with the patient on getting them in the appropriate medication and then helping them with some educational and lifestyle changes. And I think all of this has helped to mainstream the treatment of addiction and to decrease the stigma associated with addiction. So I think those are some of the important benefits. It's unfortunately, there is a need for some education and support for clinicians as they do this in general practice. But what we've done of late is to incorporate this type of training in both medical school and residency training, so that individuals become very familiar as they're developing their skills.
From Ariel Garcia, a concern about whether patients who take home medication and are basically treating themselves at home with the medication, do they receive the kind of social and emotional support that they need and that they would tend to receive when they come to the clinic every day to receive the medication?
That's an excellent question, and we've done research in this area, as have others, over the last 20 to 30 years. I think it's, first of all, important to recognize that opioid use disorder, like other conditions, occurs across a spectrum, and there are some individuals who are fairly high functioning despite their addiction, and others who require maybe more in the way of social services. And so oftentimes when we think about the treatment system, we want to make sure that we match the patient to the resources that they need. Having said that, most of the Cochrane reviews and most of the literature over the last 30 to 40 years has demonstrated that, at least with opioid use disorder, the provision of medication and some basic counseling, similar to motivational and interviewing and education that you might do for a patient with a general medical condition, seems to be adequate for a wide range of patients. Now, obviously not all patients, and so we're rethinking a little bit the necessary or the obligate role of daily counseling and visits for some patients.
Thank you. I'll put together a couple of questions here. What's the degree of culpability of the medical establishment in the United States for the widespread of use of opiates in our country? And what should government and regulators be in the lookout to prevent a push for the use of these drugs in other countries?
I think that's very important. I think, obviously there's a need for access to humane treatment around the world. And so I'm supportive of the use of opioids for, especially for acute or terminal illness and terminal pain. I think where the US got off the tracks, quite frankly, is that given that pain is such a common complaint in primary care, there was this knee-jerk response to start to use opioids universally, despite the lack of evidence that they work, especially long-term. We understand that people become physically tolerant to these, and there was really no good data to support for some patients that they benefit long-term. And so the strategy at this point is to try non-opioid treatments, try non-pharmacologic, including counseling and exercise. And then if you're thinking about an opioid for the treatment of chronic pain, making sure that you're reserving it for patients who have severe pain and monitoring whether or not they're actually responding to it and dialing it back if it seems as if they're not.
A question perhaps for Dr. Pérez Pedrogo, which has to do with harm reduction. So one of the things that you discussed, Dr. Pérez Pedrogo, is the unavailability of harm reduction throughout Latin America. And it might be useful to talk about the benefits, not only to the patients, but also to, in terms of reducing the harm of HIV, HCV, and other infections like endocarditis, but also to increase the opportunities to bring these patients into opiate treatment.
Yeah, I agree, Doctor, with you in terms of the opportunity that we are providing to people who have opioid use disorders in terms of the accessibility of treatment once the person have engaged in harm reduction programs. So I think that also harm reduction program reduce the probability of other infections such as HIV, hepatitis. So I think there's a starting point to eventually consider specialized treatments such as Buprenorphine or Methadone among this population. Also, harm reduction programs have been associated with reduction in violence rates as well as incarceration. So I think will be great if other countries also incorporate harm reduction programs in the regions.
Here at the University of Miami, in our syringe exchange program, are providing starting patients on buprenorphine treatment. Out of the syringe exchange program, we're starting patients on PrEP for HIV prevention, and we're also starting patients who are HIV positive on HIV medications, antiretrovirals, right out of the syringe exchange, and then transferring them to a HIV treatment setting or a primary care setting.
Exactly.
So they're great opportunities. And a question for Dr. Joudrey here. What do we know about other countries that may have as many restrictions as the US or as few as Canada? Do we know anything about those countries and how well they've responded in the face of the COVID epidemic?
So, and Dr. Fiellin mentioned this, one of the outcomes of the Methadone task force was an acknowledgement that there's a need right now to kind of take an international lens and compare how, and kind of shifting the focus from the medication to the system, in this case, methadone, that the medication's being delivered in. And there is some, I kind of can give a brief kind of overview, in Europe, in Europe, most countries, each country has their own delivery model, but there's a tendency for the model to look closer to what, as I gave an overview of Canada's, where, for example, the UK has a comparable model to Canada, where they allow office-based prescribing of methadone, and then methadone can be administered and dispensed in pharmacies. And there has been, over the years, both within the United States and these other countries, of course, the concern always has been balancing access with the risk of diversion. And because methadone is a full opioid agonist, there is a danger, of course, of overdose with methadone. That danger doesn't exist nearly as much with Suboxone or buprenorphine. And so there is that has been the concern, in that in different countries have taken a different approaches to balancing those two trade-offs. And I think one of the things that has come out of the task force within the United States is there's a need to systematically collect high quality data to really assess the system effects, how we choose, looking at the United States with its very regulated opioid treatment program, how that impacts that trade-off between patient access to a potentially life-saving medication, but then also the potential dangers of diversion and illicit use of methadone.
So it may be that just like in the case of other opioids, as Dr. Fiellin was saying, that when they're prescribed, the doctor has to monitor very carefully. With methadone, we also have to monitor, but perhaps for other problems like diversion or getting several doses together so that they can get high. And so as countries move towards a freer approach to dispensing methadones, they also have to put in place regulations to carefully monitor patients who are taking home medications. We are out of time. I want to thank our extremely capable speakers, as well as our audience. You have been a terrific audience. And of course, the organizers of the conference, IAPAC, and the AIDS Healthcare Foundation. Thank you so much all for this exciting panel. Good afternoon.
Buen día.